Here you see a normal size and normal colored RBC. The arrows pointing to it so you can see it in relationship to the small lymphocyte, which is the white blood cell in the center of the screen. You can also use your differential to help you discover that you have a normal size and color red blood cell population by using the MCV and the MCHC. Here you see a picture of agglutinated red blood cells. These can occur as a result of an antigen-antibody reaction within the body. We'll go into those cases when we get into blood banking. And also it can occur in cases of autoagglutination, which is a reaction of the patient's own cells with the patient's own plasma. In this case, if we're looking at EDTA sample. These occur with cold hemagglutination disease and proximal cold hemoglobinuria, which is known as PCH. This agglutination, you'll see it because it occurs when the tube's being drawn at room temperature. You'll know there's something going on as it goes through the machine because the MCHC will be greater than 36 and the MCV will be high. You'll also notice when you look at that automated result that the red blood cell count will look too low in regards to what it should be with the hemoglobin level. When you warm the specimen up to 37 degrees, this will cause the agglutination to disperse, therefore giving you an accurate MCHC and MCV reading and a nice looking peripheral smear, getting rid of that agglutination. You are looking at a picture of Rouleaux now, and you can see the red blood cells appear as stacks of coins. It's important when you observe the Rouleaux that you are in the sweet spot of the peripheral smear, as we will talk about in our 114 class. Because if you go to the thicker portion of the smear, they all start to look like Rouleaux, and that's false. That's just because the smear is too thick. This is considered Rouleaux when you are looking at the peripheral smear in the area where the red blood cells are just slightly touching. This Rouleaux is a formation that is a result of elevated globulins or fibrinogen in the plasma, and it occurs with the red cells being bathed in this abnormal plasma, and it gives them a sticky consistency. Rouleaux seen in patients with hyperproteinemias, such as multiple myeloma and Waldenstrom's macroglobulinemia. It's also sometimes seen in chronic inflammatory disorders and some lymphomas. The cells being pointed to in this picture are macrocytic red blood cells. They're red blood cells that are approximately 9 micrometers or larger. The MCV is greater than 100 femtoliters. There are a few reasons you get macrocytes. One mechanism is impaired DNA synthesis, which results in megaloblastic erythropoiesis. This leads to a decreased number of cellular divisions, therefore a larger cell. This produces a megaloblastic anemia, which can be the result of B12 or folate deficiency, chemotherapy, or any process producing a nuclear maturation defect. When you have a megaloblastic anemia, you'll see macrocytes with an oval shape. You'll also see neutrophilic hypersegmentation, and the MCV values will exceed 120 femtoliters. The most common cause of non-megaloblastic macrocytosis is accelerated erythropoiesis, which is a result from conditions such as acute blood loss or alcoholism. The reason they're macrocytic is their premature release from the bone marrow. And these macrocytic red blood cells will appear as round polychromatophilic macrocytes. And when a new methylene blue stain shows the reticulum, you can call them reticulocytes. Hypersegmentation of the white blood cells is usually not seen with this form of macrocytosis. Macrocytosis may also result from other conditions such as hypothyroidism, various bone marrow disorders. They also naturally occur in neonatal blood. They occur post-splenectomy and in cases where excess plasma cholesterol may be taken up by the red cell. This leads to an increase in the surface area of the cell. You can see a figure in your chapter book that goes into these diseases associated with macrocytes. You'll be clued in to looking for microcytes when your automated machine gives you an MCV reading of less than 80 femtoliters. You'll go to your peripheral smear and look for that lymphocyte, very small lymphocyte, a small lymphocyte having very little cytoplasm. Red blood cells that are normocytic should appear around the same size as the lymphocytes. As you can see in this peripheral smear, these red blood cells are smaller than the lymphocytes, some significantly. In this picture, the microcytes are also hypochromic. Just keep in mind that microcytosis doesn't always go with hypochromia. Sideroblastic anemia and lead poisoning produce a lot of microcytes that are usually not hypochromic. However, a consequence of a defect in hemoglobin synthesis will produce microcytic hyperchromic red blood cells. These occur in iron deficiency, thalassemia, and chronic disease states. The figure in your chapter of your hematology book can also go over pathologies associated with macrocytes. The cells you see pointed to in this picture are hypochromic red blood cells. They have a central area of pallor greater than 3 micrometers. We know to look for hypochromic red blood cells when our automated machine readings give us an MCHC less than 32%. However, if you're looking at a peripheral smear, don't be unduly influenced by what the MCHC reading is. If you see hypochromic cells, you should call them that and grade them. Usually the labs grade them 1+ to 4+, and that hypochromic grading is in your book. Keep in mind that target cells, macrocytes, and normocytes can also be hypochromic. Target cells are always hypochromic. They have the bullseye in them. And the macrocytes and normocytes, even though they're normal size or large size, can still be hypochromic. The reason I bring that up is most people associate hypochromia with microcytosis, and that's not always necessarily true. The most common disease state associated with hypochromia is iron deficiency anemia, which is IDA. In fact, IDA is called a hypochromic microcytic anemia. Hypochromic cells can be seen in alpha and beta trait thalassemia, not very pronounced, and they can be very pronounced in alpha and beta thalassemia homozygous states. Sideroblastic anemias can see a little bit of hypochromia, but they are a dimorphic blood picture, which means you'll see macrocytic, normocytic, and microcytic cells together. Lead poisoning can demonstrate hypochromic red blood cells also. In this slide, you should see several red blood cells that are slightly larger and have a different color than the other red blood cells. Instead of that pinkish color, they're a gray-blue. Those are polychromatophilic red blood cells. And this picture is of some cells that have polychromasia. And we grade them, and you can look at how the grading is in your chapter. It's the result of residual RNA, and these are actually called reticulocytes when we do a special stain on them, and we can actually stain the reticulum. But Without the special stain, we do not call them reticulocytes, we call them polychromatophilic red blood cells. And again, the picture of polychromasia. While it's normal to see a few polychromatophilic red blood cells in your smear, any clinical condition in which the bone marrow is stimulated will cause this polychromatophilic red blood cell population to increase. When you see a lot of polychromasia, it's actually telling you that the bone marrow is functioning well. It's spitting out these immature red blood cells. Conditions in which you can see polychromasia includes acute and chronic hemorrhage, hemolysis, and any regenerative red cell process. In fact, the degree of polychromasia, which they get that actual degree of polychromasia by doing the reticulocyte count, which again is a special stain on these polychromatophilic red blood cells. The reticulocyte count actually is a good indicator if iron therapy is working in the treatment of anemia. The cells being pointed to in this picture are red blood cells, specifically target cells. They're a result of an increase in the red blood cell surface membrane. Target cells are also referred to as bullseye cells or Mexican hat cells. They're seen in many types of anemia, however they're most prominent in hemoglobinopathies, thalassemias, and liver disease. Depending on what laboratory you work at, will be the way that you will grade them as to how many you see per field. That will be the same with all of these different shapes of cells that we're going to go over in the next few slides. Depending on what laboratory you're at will be how you grade the amount of these cells that you see. Keep in mind that when you're looking at a peripheral smear, you must always comment on the size and the quote-unquote color of the red blood cells. You do not have to make a note of the shape of the red blood cells unless you see something that is not normal. You have to look for them, but if you don't see any inclusions and you don't see any abnormal shapes, you do not have to make note of them. However, you must always make note of the red blood cells' size and color, even if they're normal. So a normal red blood cell size is normocytic. A normal red blood cell quote-unquote color is normochromic. Target cells are also referred to as caudocytes. Spherocytes are a result of a reduction in the surface to volume ratio of red blood cells. They're actually hyperchromic, but as we know from our readings, we do not call cells hyperchromic. We can call them normochromic, we can call them hypochromic, but we do not call cells hyperchromic. The congenital condition that causes spherocytosis is called hereditary spherocytosis. And in half the cases, the MCHC will be genuinely greater than 36%. So the MCHC is not falsely elevated due to a problem with like cold agglutinins. Hereditary spherocytosis is a hemolytic anemia. It can be either mild and go all the way to severe. The acquired form of spherocytosis shares the mutual defect with hereditary cytosis, but it usually does not result in an anemia. Autoimmune hemolytic anemia results in spherocytosis, and it's a mild to severe anemia. And any hemolytic process may result in spherocytes. Spherocytes do have an increased osmotic fragility. Please note that burn victims can have microspherocytes, as you see in this slide. Stomatocytes are a result of a membrane defect. Stomatocytes derive from the Greek word stoma, which means mouth. Their area of central pallor looks slit-like or mouth-like on peripheral blood smears. They're normal size, but they're not biconcave. Stomatocytes usually are artifactual. The way you can tell the difference is that the artifactual stomatocytes have a distinct slit-like area of centropolar. A genuine stomatocyte has a shaded area of polar. Stomatocytes can be found in hereditary spherocytosis, hereditary stomatocytosis, hemolytic anemia, alcoholic cirrhosis, and acute alcoholism. They can appear on the blood smear of patients with Rh null disease, and you may look at the morphology, spherocytes, and the pathologies associated with them in your chapter. While in many labs there's no differentiation between ovalocytes and elliptocytes, laboratories call them just ovalocytes, it's important for us to know the difference. Elliptocytes are those cigar-shaped cells that you see on the right-hand side of the screen underneath elliptocytes. Ovalocytes, specifically macrovalocytes, seen on the left part of your screen under ovalocytes, are associated with the megaloblastic anemias. Sickle cells are also known as trypanocytes. In the homozygous patient, low oxygen tension causes the abnormal hemoglobin to polymerize. These sickle cells have lost their ability to form and in many cases are unable to negotiate the microvasculature of the tissues. This leads to oxygen deprivation in those areas. The picture that you have on your slide is a picture of an irreversible sickle cell. It's a result of repeated sickling episodes. Look in your book, in your chapter, at the oat-shaped sickled cells. Those forms have less pronounced projections and the central area of the cell is fairly broad. That shape is reversible. Sickle cells are not usually seen in the peripheral smears of individuals who are heterozygous. Schistocytes are the extreme form of red cell fragmentation. Whole pieces of red cell membranes appear to be missing and bizarre red cells are apparent. They occur in patients with microangiopathic hemolytic anemia, disseminated intravascular coagulation, otherwise known as DIC, heart valve surgery, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, renal graft rejection, vasculitis. They occur in severe burn cases, as well as March hemoglobinuria. Read in your book about helmet cells and keratocytes. Burr cells are seen in uremia, heart disease, cancer of the stomach, bleeding peptic ulcer, immediately following an injection of heparin, and in a number of patients with untreated hypothyroidism. In general, they may occur in situations that cause a change in toxicity of the intravascular fluid. For example, dehydration. Burr cells may be considered pathologic and should be reported. The other name for a Burr cell is an acanthocyte. It's useful to keep in mind that Burr cells can be observed as an artifact, usually as a result of specimen contamination. An acanthocyte, like a target cell, has an excess cholesterol to phospholipid ratio. It essentially is a spherocyte with thorns. However, the MCHC is always in the normal range. The only inherited condition in which acanthocytes are seen in high numbers are in the rare condition of beta-lipoproteinemia. Most cases of acanthocytosis are acquired. such as patients with severe hepatic disease. It is also seen in alcohol intoxication, vitamin E deficiency, and post-splenectomy. Macrocytes, otherwise known as teardrop cells, look just like what the description is. They look like teardrops. The exact physiologic mechanism is unknown, yet teardrop formation from inclusion-containing red cells is well documented. They're usually seen in idiopathic myelofibrosis. They can also be seen in thalassemia, in drug-induced Heinz body formation, in iron deficiency, and in conditions in which inclusion bodies are found. It can also be seen in megaloblastic processes, and there'll be macrocytes, so there'll be macro teardrops. We're now moving on to inclusions. It's very important when you're reading a peripheral smear that you make note of any red cell or white cell inclusions that you see. If you don't see any inclusions, you don't need to make note of it. Howell-Jolly bodies are nuclear remnants containing DNA. Howell-Jolly bodies may be seen after surgical splenectomy, congenital absence of the spleen, or splenic atrophy after multiple infarctions. They may also be seen in patients with thalassemia, sickle cell anemia, other hemolytic anemias, and in megaloblastic anemia. Be sure you're starting to think about these disease states. We know of the inclusions now seen in thalassemia, sickle cell, hemolytic anemia, megaloblastic anemia, at least one of them. You should start thinking, what size, shape, and color do I see in those same disease states? For example, in thalassemia, what kind of shapes of red cells may I see? What is the size and color of the red blood cells? Do the same process with iron deficiency. The same process with megaloblastic anemia. Aggregates of ribosomes appear as stippling as the cells are drying in preparation for microscopic examination. Basophilic stippling may be found in any condition showing defective or accelerated heme synthesis, such as alcoholism, thalassemias, megaloblastic anemias, and arsenic intoxication. It is also considered a characteristic feature in the diagnosis of lead poisoning. It's important not to confuse basophilic stippling with Pappenheimer bodies. Basophilic stippling appears homogeneously all over the cell. Pappenheimer bodies tend to appear as clusters in the cell periphery. Pappenheimer bodies appear in clusters as if they have been gently placed on the red cell membrane. When we see them on our peripheral smear, which is a right-stained smear, it's presumptive evidence for the presence of iron. However, the Prussian blue stain is a confirmatory test for determining the presence of these inclusions. When these inclusions are seen with the Prussian blue or other kind of iron stain, they are called siderotic granules. Once the presence of siderotic granules has been confirmed by iron stains, these cells are now called siderocytes. Siderocytes containing a nucleus are described as sideroblasts, and sideroblasts are commonly seen in sideroblastic anemias. Sideroblasts exhibiting numerous siderotic granules found within the mitochondria forming a ring around at least 1/3 of the nucleus are labeled as pathologic ringed sideroblasts. Siderocytes are seen in any condition in which there is iron overloading, such as hemochromatosis or hemosiderosis. It can also be seen in the hemoglobinopathies and in patients following splenectomy. And again, hemoglobinopathies include sickle cell anemias and thalassemia. It's important to note that Heinz bodies are seen with a special stain. They will not be seen on right-stained peripheral smears that are normally done in the lab. Heinz bodies are formed as a result of denatured or precipitated hemoglobin. They can be seen in alpha thalassaemic syndromes, glucose 6-phosphate dehydrogenase, G6PD, under oxidant stress, and in any of the unstable hemoglobin syndromes. Example, hemoglobin Cone, hemoglobin Zurich. They may also be seen in red cell injury resulting from chemical insult. While this Cabot ring looks more circular than figure 8, this is a Cabot ring. You should also notice heavy basophilic stippling, and what's noted as B on this slide is the Howell-Jolly body. Cabot rings are found in megaloblastic anemias, thalassemia syndromes that are homozygous, and post-splenectomy. In this slide, you will see the hexagonal-shaped crystal inclusions. This is from a patient with hemoglobin C disease. They may not always be demonstrating hemoglobin C disease, but their appearance has been found to increase after splenectomy. Hemoglobin C crystals are not seen in hemoglobin C trait. Hemoglobin C crystals are said to resemble a bar of gold. SC crystals are seen in hemoglobin SC. The projections have been said to resemble the Washington Monument. Therefore, SC crystals may be referred to as Washington Monument crystals. Protozoan inclusions are important to make note of, as seeing them on a blood smear is confirmation of infection by the organism. In this slide, you're looking at Plasmodium malaria. Babesia microti is also an organism that invades red cells. It's transmitted by tick bites. Malaria is transmitted by mosquitoes. In these two pictures, we're looking at toxic changes to white blood cells. Toxic changes occur due to severe infections, inflammatory conditions, or other leukemoid reactions. On the left, we can see the vacuoles. They look like the bubbles in one of the cells over there. It looks like a band. It's that group of 3, and it's in the middle of that group of 3. You can see the vacuoles there. All 3 of the neutrophils look like they have toxic granulation. And those are the medium to large granules that are evenly scattered throughout the cytoplasm. And toxic granulation occurs in these segmented neutrophils. Over to the right, you can see 2 Dolly bodies. There's 2 blue dots in there. Those are also a result of infections. Dolly bodies are oval blue, single or multiple inclusions originating in RNA. They can be seen in patients with severe infections, in patients with severe burns, in pregnant women, and in patients receiving chemotoxic drugs. It's important when looking at platelets that you don't go along the periphery of the smear. That tends to be where platelets will clump together, and that's not a true picture of platelets. If you see on the left-hand side, that's a picture of a platelet clump. It's important to make note of those because they may actually cause the automated machine to read the platelets as lower than they actually are. When you get a lot of platelet clumps like that, you need to get a blue top tube to correct that issue. Sometimes platelets will satellite around neutrophils. That 2 is due to EDTA. In the middle you have a large platelet, and on the right hand side, that big blue blob there that's to the left of that neutrophil, segmented neutrophil, is a giant platelet. Those all must be noted when you're doing a peripheral smear reading.